For a long time, the fight against cancer has felt, well, kind of like a sledgehammer approach. Powerful, sure, but not very precise. But what if we could move beyond that brute force? Today, we're going to talk about a revolution that's happening right now in cancer treatment, a move towards smarter, more targeted weapons that are changing the entire game.
So why is this revolution so incredibly important? It really comes down to this one pretty staggering number, 90%. Think about that for a second. That's the percentage of cancer-related deaths caused not by the first tumor, but when the cancer spreads, a process called metastasis. That right there is the biggest mountain we have to climb.
And this slide just lays out the whole idea perfectly. We're shifting from the old way, chemotherapy, which is like a carpet bomb. It hits the bad guys but causes a ton of collateral damage, to the new way, targeted therapy. This is our smart bomb. It's engineered to go after very specific weaknesses found only in cancer cells, which means much less harm to the healthy cells around them.
All right, so to really appreciate just how much of a game changer this is, we first have to get a handle on the old problem, the challenge that doctors and scientists have been wrestling with for decades.
You see, chemotherapy is, well, it's a blunt instrument. Its main strategy is just to kill any cell that's dividing rapidly. And sure, that works for cancer. But you know what else divides rapidly? The cells in our hair, the lining of our stomachs, our bone marrow. And that is the collateral damage. It's what causes those famously harsh side effects and really takes a toll on a patient's quality of life.
And you know, for patients whose cancer has already spread, the fight is even harder. A statistic like this one for metastatic breast cancer, it's just sobering. It really hammers home why we so urgently need better, smarter treatments. For these patients, this isn't just theory. It is quite literally a matter of life and death.
Okay, so if chemo is the sledgehammer, what's the scalpel? Let's get into the central idea behind this smarter way to fight, targeted therapy.
The magic word here is target. Instead of just wiping out any cell that's growing fast, these drugs are designed to find something unique about the cancer cell, a specific protein, maybe a mutated gene, and attack that. That, in a nutshell, is the foundation of what we call precision medicine.
Now, these smart weapons come in two main flavors. On one hand, you have what are called small molecule drugs. These are tiny enough to actually slip inside a cancer cell and jam up the machinery from within. Then you have monoclonal antibodies. These are much larger proteins. Think of them as working on the outside, kind of like putting superglue in the keyhole so the cell can't get the signal it needs to grow.
So that's the theory. But how do these therapies actually hit their targets in a real person? Let's make this concrete and look at some examples from colorectal and breast cancer.
To really get this, we need to understand the cell's internal communication network. It's called a signaling pathway. It might sound complicated, but it's basically a chain of command. A message arrives on the outside of the cell and gets passed down from one protein to the next until an order is delivered, an order like time to grow and divide.
In many cancers, this very chain of command gets hijacked. A growth signal shows up and docks with a receptor on the cell's surface. A common one is called EGFR. That flips a switch on the next protein in line, maybe one called RAS. And what's the final order? Grow, divide, and don't stop.
Now here comes the smart part. A targeted drug like cetuximab, which is one of those monoclonal antibodies, is designed to physically block that EGFR receptor. It's like posting a guard at the door. The signal arrives, but it can't dock. The message is never delivered. The order to grow is never issued. It's pretty brilliant.
But, and this is a huge but, what if the problem isn't the signal coming from the outside? What happens if a switch further down the line is already broken and just jammed in the on position, no matter what?
Well, a mutation in a gene called KRAS causes exactly that problem. It's like that switch is permanently on. So in that case, blocking the signal at the surface is totally useless, right? The command to grow is already on a runaway loop inside the cell. And this is precisely why genetic testing is not just a nice-to-have, it's essential. You have to find out which part is broken to choose the right drug.
And the level of detail here gets absolutely fascinating. It turns out that in colorectal cancer, even the location of the tumor matters. Tumors on the left side of the colon often respond well to those anti-EGFR drugs we were just talking about. But tumors on the right side, they tend to do better with a completely different kind of targeted therapy.
So what's that other therapy doing? It's going after a different process called angiogenesis. You see, for a tumor to get big, it needs to build its own blood supply, a fuel line, to bring in oxygen and nutrients. Drugs called anti-VEGFs are designed to block this process, to basically cut the fuel line and starve the tumor.
Now, let's switch gears for a moment to breast cancer. In about 15 to 20% of cases, the culprit is a different receptor called HER2. In these particular cancers, the cells have way too many of these HER2 receptors. The best analogy is that it's like a car's accelerator pedal is just stuck to the floor. So, of course, there are drugs designed specifically to pry that pedal up.
And this field is definitely not standing still. The arsenal of these smart treatments is expanding at an incredible rate, with all sorts of innovative new strategies coming into play.
I mean, just look at this timeline. The first big targeted drugs for colorectal cancer got approved back in 2004. But just fast forward to the last few years, and you see an absolute explosion of new ideas. New classes of drugs, powerful immunotherapies, and some incredibly clever delivery systems, all getting the green light. One of the most elegant new ideas is something called an antibody-drug conjugate, or ADC. Honestly, the best way to picture it is as a Trojan horse. You take one of those targeting antibodies that's great at finding cancer cells, and you attach a super potent chemotherapy drug to it. The antibody guides the payload to the cell invites it inside, and only then is the chemo released, killing the cell from within while sparing the healthy tissue. It's just brilliant. Another massive breakthrough is immunotherapy. Some cancers are masters of disguise. They put up a signal that tells your own immune system, hey, nothing to see here, move along. What these drugs do is block that hiding signal. They effectively take the brakes off the immune system, allowing your body's own T cells to finally see the cancer for what it is and go on the attack. So, with all these amazing new tools, where are we headed? Let's talk about the road ahead, the challenges that remain, and the incredible promise of this personalized approach. The biggest challenge, without a doubt, is drug resistance. Cancers are smart. They evolve and find new ways to grow. So the strategy is to get even smarter. By using intelligent combinations of therapies, targeting multiple weak spots at once, the hope is to corner the cancer so it has no escape route. The goal for many advanced cancers is now shifting, to turn them from a death sentence into a manageable, chronic disease. And all this leaves us with a pretty profound question. For decades, we've talked about finding the cure for cancer, as if it's some single silver bullet. But this new era of precision medicine, it really suggests a different future. Is the goal a single cure for everyone? Or is it really about cracking a unique, personal code for every single patient?